Okay, let's unpack this. Imagine your body is this uh, incredibly fine-tuned machine, right? Always working behind the scenes to keep its internal chemistry perfectly balanced.
Hmm.
We're not just talking about the obvious things like breathing or your heart beating. It's this microscopic dance, acids, bases, ions,
Mm.
all keeping things humming.
It's incredibly precise.
Exactly.
Yeah.
And today, we're taking a deep dive into one specific way that delicate balance can get knocked off course. It's a condition called metabolic alkalosis.
Right. And maintaining that acid-base balance, it's just fundamental to health. So when it's disrupted, like in metabolic alkalosis, it really shines a light on how interconnected everything is, down to the cellular level, really.
Absolutely. So to get our heads around this, we've pulled together a bunch of sources, expert texts, research bits that really lay out the details.
Good stuff.
Our mission for this deep dive, to pull out the key nuggets from these sources. We want to understand exactly what metabolic alkalosis is, why it happens, how it shows up, how doctors figure it out, and importantly, how it's managed.
So by the end, you should have a really solid handle on it.
Yeah, and hopefully appreciate just how complex that internal balancing act really is.
Think of it like getting a peek behind the curtain, seeing one of the body's essential control systems and what happens when its pH just gets nudged a bit too high.
All right, let's pull back that curtain then, starting with the basics. What is metabolic alkalosis, according to these sources we looked at?
Okay, so at its core, metabolic alkalosis is defined by two main things you see in the bloodstream. First, a high pH.
High pH, meaning less acidic, right? A lower concentration of hydrogen ions,
Yeah.
H plus dread.
Exactly. And second, a high concentration of plasma bicarbonate.
Okay, high pH and high bicarbonate. And the sources say this happens in, one of two main ways.
That's right. Fundamentally, it's either the body effectively gaining too much bicarbonate, which is a base,
Right.
or it's losing too many hydrogen ions, losing acid. That imbalance just shifts the whole equilibrium towards being more alkaline.
Got it. Too much base coming in or too much acid going out. So how does the body actually end up in that state? What kind of situations lead to this?
Well, our sources point to several common culprits. One of the really prominent ones is severe vomiting or using gastric suction.
Ah, like when you lose a lot of stomach acid.
Precisely. Your stomach makes hydrochloric acid, HCl, that's hydrogen ions, H plus bia, and chloride ions, Cl. When you lose that really acidic fluid, maybe through intense vomiting or a tube doing gastric suction, especially in situations like, say, pyloric stenosis, where only stomach fluid is lost,
Okay.
the bloodstream is losing those acid components.
But how does losing acid from the stomach make your blood alkaline? That seems a bit indirect.
Yeah, it does, but think about it. The body tries to replace the acid you just lost, right? To make more HCl for the stomach, it has to pull hydrogen ions from the bloodstream.
Ah, okay.
So as the bloodstream loses those H plus ions to supply the stomach, the blood itself becomes less acidic. Its pH goes up, it becomes alkalotic.
That makes total sense now. Losing acid from one place forces the supply line, the blood, to become more alkaline. What else? You mentioned something about potassium loss.
Yes, absolutely. Situations where the body loses a lot of potassium are very strongly linked. This includes using certain diuretics, water pills, things like thiazides or furosemide. They're known to make the kidneys push out more potassium. It can also happen with conditions involving too much ACTH hormone secretion, leading to excess mineralocorticoids like in hyperaldosteronism or Cushing syndrome.
Okay, now this is where it gets really interesting and honestly a bit confusing at first. How does low potassium hypokalemia lead to alkalosis? They seem like different things.
Yeah, this is one of those crucial insights from the sources about the body's complex trade-offs. Our sources explain that low potassium contributes to alkalosis in, well, two specific ways.
Okay.
First, it involves the kidneys, those little filtering units, the nephrons. When your blood potassium is low, the kidneys go into overdrive trying to reabsorb potassium back into the blood. Potassium's vital,
Right.
So, to help grab that positive potassium ion back and keep things electrically balanced in the kidney tubules, the nephrons end up secreting hydrogen ions into the urine instead.
Whoa. So the kidney basically sacrifices acid, H plus A, to save potassium.
In a manner of speaking, yes. You lose H plus in your urine, meaning the blood loses H plus A, and that makes the blood more alkaline.
Okay, that's one way. What's the second?
The second way is happening at the cellular level. So when blood potassium is low, the potassium that's normally inside your cells starts to move out into the fluids surrounding the cells, the extracellular fluid.
Try to bump up the blood level.
Exactly. But when positive potassium ions leave the cell, other positive ions have to move into the cell to keep the electrical charge balanced. And guess which positive ion tends to move in?
Let me guess. Hydrogen ions.
You got it. Hydrogen ions move from the extracellular fluid into the cells.
Wow. So low potassium makes your kidneys dump acid and makes your cells suck up acid from the bloodstream. That's quite the double whammy for causing alkalosis.
It really is. It shows the body trying to protect vital intracellular potassium levels, but the side effect is creating alkalosis in the blood. It's a definite trade-off.
Are there other ways the sources mention that you might gain too much base?
Yeah, simpler ways too, like just taking in too much alkali. The classic examples are taking loads of antacids that contain bicarbonate or using sodium bicarbonate, like sometimes happens during CPR.
Right, direct intake.
Yeah.
And the sources also briefly listed some conditions that can cause chronic alkalosis, like long-term stuff.
Yep. They mention chronic diuretic use, certain rare GI tumors like villus adenoma, ongoing external gastric drainage, significant long-term potassium depletion, the genetic condition cystic fibrosis, and also chronic intake of lots of milk and calcium carbonate, like old ulcer remedies sometimes involved.
So quite a range of causes, from fluid loss to meds to rarer things. Okay, so once this imbalance is established, what does it actually feel like? What does it do to you? How does metabolic alkalosis manifest?
Well, according to the sources, the main way the symptoms show up is often tied to calcium.
Calcium. How does alkalosis affect calcium?
Okay, so with fewer hydrogen ions, H plus calcium, floating around in the alkalotic blood, there are more negatively charged spots available on proteins, like albumin, that would normally bind to some H plus book. These free spots now attract other positive ions. Specifically, they start binding calcium ions, K+++.
So the calcium that's usually free in the blood starts sticking to these proteins instead.
Exactly. And as more calcium binds to protein, the amount of free, or what we call ionized, calcium circulating in the blood goes down. This creates a state of hypocalcemia, but specifically a drop in the ionized fraction.
And that's the important part, right? The ionized calcium is the biologically active form that nerves and muscles actually use.
That's absolutely key. Because that active ionized fraction is lower, the symptoms you see are often mainly neuromuscular. The sources list things like tingling, especially in the fingers and toes.
Pins and needles kind of feeling.
Yeah, exactly. Also dizziness and muscle cramping or spasms. In severe cases, that's called tetany.
Makes sense. Low active calcium makes nerves and muscles sort of jumpy. Does the body try to fight back against the alkalosis? Are there compensation mechanisms?
Oh yes, it tries. The lungs jump in first. They attempt to compensate by slowing down your breathing rate. You breathe slower, shallower.
Wait, how does breathing slower help fix high pH?
Slower breathing means you hold on to more carbon dioxide, CO2, in your blood. The sources mention the carbonic acid equation, basically. CO2 combines with water to make carbonic acid, which quickly releases hydrogen ions, H plus col.
Ah, so holding on to CO2 means making more acid in the blood.
Effectively, yes. It increases the H plus concentration, helping to nudge the pH back down towards normal, or at least trying to. Although the sources do note this hypoventilation can be more of an issue in patients who aren't fully alert, and it could potentially lead to low oxygen levels, hypoxemia.
Okay, so the lungs try to retain acid by retaining CO2. What about the kidneys? They're usually the big guns in acid-base balance.
They are. If the kidneys are working properly, they'll also try to help. They do this by increasing how much bicarbonate, the excess base, they excrete in the urine.
Getting rid of the base.
Right. And at the same time, they try to conserve hydrogen ions, holding on to acid. It's the kidney's way of trying to reduce the alkalinity.
Okay, so dump base, keep acid. Seems logical, but hang on. Didn't you say earlier that low potassium causes alkalosis partly because the kidneys secrete H+? How does that square with the kidneys now trying to conserve H+ to fix the alkalosis? That sounds contradictory.
Yes. This is one of those really crucial, complex loops the sources point out, especially when hypokalemia is involved. As the body, including the kidneys, tries desperately to conserve hydrogen ions to lower that high blood pH.
Right.
The nephrons, driven to maintain electrical neutrality and grab whatever positive ions they can, end up excreting potassium ions instead of the H+ they're trying to save.
Oh, no.
Yeah, so the kidney's attempt to fix the alkalosis by holding on to acid actually makes the low potassium worse. And since the low potassium is driving the alkalosis in the first place through those mechanisms we talked about.
It creates this awful vicious cycle. Low potassium causes alkalosis. The attempt to fix the alkalosis worsens the low potassium, which then just perpetuates the alkalosis.
Wow. It's a perfect illustration of how interconnected these things are and why just treating the pH isn't enough. You have to fix the underlying cause, like the hypokalemia.
That's a really powerful insight.
And the sources also mention other issues specifically tied to that ongoing low potassium. Things like changes on an ECG, that heart tracing, you might see a prominent U wave, or even heart rhythm problems like ventricular disturbances, PVCs, plus decreased gut motility, sometimes even leading to a paralytic ileus where the bowels just stop moving.
So the symptoms aren't just from the pH being off. The root cause, like severe hypokalemia, brings its own set of problems too. Okay, so we know what it is, the causes, the effects. How do clinicians actually diagnose this? How do they figure out, okay, this is metabolic alkalosis?
The main diagnostic tool mentioned in the sources is the arterial blood gas, the ABG.
Right, the blood test from the artery.
Exactly. It measures pH, oxygen, CO2, bicarbonate, and looking at the ABG shows those telltale signs. A pH higher than 7.45 and a serum bicarbonate level greater than 26 MEQL.
Which matches the definition we started with. High pH, high bicarb.
Precisely. And you'll often see the PET2, that's the carbon dioxide level in the arterial blood starting to creep up too as the lungs try to compensate by holding on to CO2.
Okay, so the ABG confirms the alkalosis.
Right.
But how do you figure out why? There were so many possible causes you listed earlier.
Right. And this is where measuring urine chloride levels becomes really useful. It's fascinating, actually. The sources state that urine chloride can sometimes be a better indicator of the body's overall fluid volume status in this specific situation than even urine sodium.
Really? Better than sodium?
Context, yeah. But more importantly, the urine chloride level is a great diagnostic clue. It helps pinpoint the cause of the alkalosis, especially if the patient's history isn't totally clear.
How does urine chloride help sort out the causes?
The sources draw a pretty clear line. If the urine chloride is low, usually less than 25 millieql, you tend to see that in patients with vomiting, cystic fibrosis, maybe those getting IV nutrition repletion, and people on diuretic therapy.
Okay.
These causes are typically linked to being volume depleted, low fluid volume, or hypovolemia, and also having low chloride levels, hypocalcemia. Although the sources add a little note that signs of low volume might not always be super obvious just from the urine chloride number itself in these cases.
Okay, so low urine chloride suggests causes where you're losing fluid and chloride, like vomiting or diuretics. Makes sense your body would try to hold on to chloride in the urine if you're low overall.
Exactly. Now, on the flip side, if the urine chloride is high, say greater than 40 milliQL, that points towards different causes. Things like mineralocorticoid excess syndromes, like hyperaldosteronism, or situations where someone has had excessive alkali loading, like taking too much bicarbonate.
Right.
And these causes, the sources link them to having normal or expanded fluid volume. Signs of hypovolemia are typically not present in these folks.
Got it. So high urine chloride suggests causes where fluid volume is okay, or even high, like hormone issues or alkali intake. That's a really neat way to help narrow down where the alkalosis is coming from.
It's a key differentiator between those volume-depleted causes and the volume-expanded ones. Really helps guide treatment.
Okay, perfect. So we know what it is, the causes, the symptoms, the diagnosis using ABGs, and that helpful urine chloride test. Final piece. How do we fix it? What's the medical management look like based on these sources?
Well, the number one goal, according to the sources, is always to correct the underlying problem, the root cause of the acid-base disorder. You can't just, paper over the cracks.
Makes sense. Treat the cause, not just the number.
Exactly. And since volume depletion is so common, especially with GI losses like vomiting or suction, keeping a really close eye on intake and output INO is crucial. Tracking fluid balance.
Okay, watch the fluids carefully. What about specific treatments the sources mention?
Well, if volume depletion is the issue, restoring normal fluid volume is paramount. The sources specifically talk about giving intravenous normal saline.
Salt water.
Yeah, salt and water. And it's critical because remember that vicious cycle. Continued volume depletion actually perpetuates the alkalosis. Giving saline helps break that.
How does saline help fix alkalosis?
It replaces both the water and the chloride that's often lost along with the hydrogen ions, especially in vomiting or gastric drainage. Getting that chloride level back up is really important because low chloride, hypokalemia, makes it harder for the kidneys to excrete bicarbonate. Okay, so the chloride in the saline is key too.
Very key. And if hypokalemia low potassium is present, which it often is, then potassium needs to be given. Specifically, the sources mention giving it as potassium chloride, KCl.
Potassium chloride. Why the chloride part specifically?
Good question. Because, as the sources explain, giving KCl replaces both the potassium deficit and the chloride deficit. Remember, low chloride also helps keep the alkalosis going. So KCl tackles both problems at once.
Got it. Fixes the potassium and gives the chloride needed to help the kidneys sort out the pH. Smart.
Exactly. Now, for causes related to losing too much stomach acid, like ongoing vomiting or suction, the sources recommend proton pump inhibitors, PPIs, like omeprazole.
Those are common acid-reducing meds, right?
They are. They work by reducing how much HCO the stomach produces. Less acid produced means less acid lost, which directly helps lessen the alkalosis.
A targeted approach. Makes sense. Any other medications mentioned? Yes. One more group. Carbonic anhydrase inhibitors. Acetazolamide is the example given. These are noted as being useful, particularly for patients who can't tolerate getting a lot of fluid quickly.
Like someone with heart failure, maybe.
Exactly. Someone like that, where giving lots of saline could cause problems. Acetazolamide works differently. It acts directly on the kidneys, at the nephrons, to basically force them to excrete more bicarbonate.
So it helps get rid of the excess base without needing all that extra fluid volume.
Precisely. It's another tool in the toolbox, a different mechanism to help lower the pH by getting rid of bicarbonate.
Wow. Okay. So we've really covered a lot of ground here on metabolic alkalosis. Started with the basic definition, high pH, high bicarb. Explored all those diverse, sometimes surprising causes, vomiting, diuretics, that tricky low potassium link, even antacids. We saw how it can show up with symptoms like tingling and cramps, often tied to that calcium level disturbance. Learned how critical labs like ABGs and that urine chloride test are for diagnosis and finding the cause.
Yeah, the urine chloride's pretty neat.
And finally, looked at how it's managed, focusing on the underlying cause, fixing fluids, potassium chloride, and using specific meds like PPIs or acetazolamide when needed. It really is a masterclass in the body's intricate balancing act.
It really is. And what's striking is how things we encounter often, severe vomiting, common medications can spiral into these significant systemic issues affecting acid base, electrolytes like potassium and calcium, even breathing and gut function. It just highlights how interconnected everything is.
It absolutely does. And it kind of leaves you thinking, based on these sources, how does the body prioritize? When it's faced with these disruptions, how does it decide whether to balance hydrogen ions or potassium or calcium first? What does that juggling act tell us about the resilience and maybe the vulnerability of these systems?
That's a great question. Or even just thinking about how everyday things, common meds or conditions, can have these really complex, sometimes unexpected downstream effects on our fundamental body chemistry.
Yeah, it's truly an intricate dance happening inside us all the time. Makes you appreciate the balance.